we have seen the importance of knowing the ethical principles like autonomy, beneficence, maleficence, and fair allocation of the resources in properly, deciding about the management for COVID and how to triage patients with COVID according to, according to the guidelines and looking at their comorbidities so as to avoid futile treatment and then to provide appropriate symptom control so as to effect an enhanced quality of life and comfortable end of life is. On the second day, Sunitha Daniel spoke to us regarding the common symptoms with which a COVID patient can present, and we have focused on the most distressing symptoms like pain, breathlessness, agitation, ranging from the mild presentation through moderate to severe symptoms, severe presentation. And the first and second day, we had a lot of queries and concerns regarding communication challenges which is happening during COVID-19 pandemic, because it's like an emergency. So we don't have much time to interact with the patient and the family. So on the third day, yesterday, we had seen how effectively communication can be done, even though the time is quite less. And we have all the barriers in communicating to the patient and the family. And we had seen, the common challenges and how effectively it can be tackled. So we have crossed all those things, and we had been with Ramesh and his family during all these days. And today, let us see what is going to happen to Ramesh and his family. And, so that's the most important of all. I'm not belittling the other previous sessions, but facing and handling the end of life care issues is a real challenging scenario for any person, particularly for healthcare professional, because we are trained to save lives and to delay or postpone death, though all of us know that it is inevitable and going to happen. So today we have Dr. Shoba Nair, who is a professor of palliative medicine from Amrita Institute of Medical Sciences, and she had been one of the pillars in the development of or the evolution of the whole, what we are witnessing today, like PalliCovid ECHO program, and she had contributed enormously to the toolkit. So welcome, Shoba, to the group, and it's over to you. So I invite all participants to post their comments. We will regularly visiting the chat box to have the discussion in between. Thank you.
Right. I hope I'm loud and clear.
Yes, ma'am.
Okay. Right. Okay. So, right. Good afternoon, everyone. I hope you had a very fruitful last 3 days discussing about various aspects of palliative care in COVID patients. So today we're going to discuss about a very important aspect of life, which is death. So medical fraternity, I think in general, we always focus on life, and if we feel that, okay, we cannot contain certain diseases, we sort of quickly give up and say, nothing can be done, please take these patients home. Well, as physicians, as healthcare professionals, it's our responsibility to not only look after them when they're alive, but also during their last days. These slides have been prepared by my colleague, Rajashree. So thank you for that. And I'm just using her slides to go through this lecture. So if some points are not clear, I'm sure Raji is going to pitch in and help with the slides. Okay. So before we go any further, I'm sure like you would have seen this before. This outline before, wherein we always have a learning objective. So here, the learning objective is death as a natural event is what we are emphasizing on. Learning the importance of end-of-life care, and emphasizing the relevance and challenges of end-of-life care in COVID-19 patients. Principles and mentioning the strategies of good end-of-life care. So I'm sure you would have gone through this link and downloaded the ebook and also the PalliCare app. Both these are very good resources in India and also other neighboring countries where Asian countries where we can put this into practice. So before we go any further, I would like you to sort of think about what do you understand about death? Have you ever thought about it? What is your perspective? Or can I say, when you hear the word death, what comes to your mind? Could you put that in the chat box, please?
Fear.
Okay.
Okay. Oh, fear again.
Here. Peace.
Peace. Oh,
Okay.
peace. Yeah. Unknown.
Unknown. Okay.
Truth. Yeah. And coming home. End of suffering. Final healing.
Okay.
Very
So
philosophical.
yeah, so, so
Yeah.
so many ideas come to your mind, is it? So when we talk about end of life care, we always think it is for the other person and not for ourselves. We always fail to put ourselves in that shoes and think for a second, what would the dying person want? And what did he go through till he got to this state in his life? And are we actually respecting that person when he is in his deathbed? Is something which we want to look at. So, do you think that death can be a happy process? Any comments on that?
Sorry, Shobha, I didn't hear that.
Can death be a happy process, or we are wishing that death happens?
Yeah, okay,
Can
okay.
there be some scenario like that?
So Shobha is asking whether death can be a happy process. Probably as a response to your previous question, what will happen to people we have left? Oh yes, we can wish. Can it be peaceful, no pain, and surrounded by family, well prepared, and closure has been well processed? Absolutely.
Yeah. So if it's
Listening
peaceful,
to the
it can be a
patient and
happy
family.
process. Is what people say.
If there is an understanding in advance, probably that can be made peaceful and happy. And Dimkumari is commenting that it's a mixed feeling. And probably all of you will be mentioning that it's quite subjective. It may vary from person to person. Am I right, Shobha?
Yeah, yeah, absolutely, absolutely. So, so we are saying that death. Some of you said it's fear, end of life. There's no further progress, and when we think about it, and some answers about whether it can be peaceful is okay. We can wish for that. If can I say if the life is too distressing, then sometimes we wish for a peaceful death. Is that a right perspective? There's so much of suffering that we wish this person would die quickly. Have you ever had that? Have you ever had that kind of a feeling as healthcare professionals?
Yeah, for many people. And I do
Okay.
think for many people who are outside the medical fraternity also, no, they might have experienced that kind of thought at least once in their lifetime. Oh, it would be much better if I mean, finish off everything. Yes, it's wanted. Okay.
Absolutely. Okay. Now the next question is: so we talked about death being end, being fearful, being peaceful, happily embracing death when the suffering is too much. Can the death be glorified in any circumstance? Can death be glorified? What's your idea? Do you think death can be glorified? Anyone?
I believe so. From
Okay.
Tricia.
Okay. Can you give an example where death can be glorified?
Tricia, please post your, comment on that you believe that can be glorified. End of physical suffering. Is that the reason why you said that can be glorified? Reunited with the Creator?
Okay. Right. So is there a circumstance, let me put it another way, is there a circumstance in which where we give a lot of respect to the dead person? Can I think of a scenario? This is just a mindful exercise for you to warm up to the topic on death.
Yeah,
Nothing.
exactly.
Yeah.
Celebrating life lived. Martyr in a war.
Excellent. Okay, so that's what I was looking for, martyr in a war. Okay, I'm going to stop share for a second. I'm going to show you a photograph, if that's okay.
Shoba,
Yeah,
are you there?
coming up, coming. Yes, I'm coming. 1 second. 1 second. Can you see this? Can you all
Yes,
see
ma'am.
this? Yeah.
Yes, ma'am.
Right. Okay. So this is a young army personnel by name Anish Thomas, who died on 15th of this month in unprovoked firing in the border from Pakistan. So, and his body was brought to the Trivandrum airport this morning, and there was a ceremony there saluting him, and he's laid his life for our country. So, martyr's life, yes. So death can be glorified in such a circumstance. Although the family bereaves, we all feel unhappy that this has happened. There's so much of respect for this gentleman. And there will be so many followers who might take up to this kind of a life in future, because so many people get inspired. All right. Okay. Now let's move on back to our presentation. Sorry, I'm taking a bit of a time. So here we go. Different thoughts from different parts of the world. Okay. So there's somebody who's a Mexican author. She's a writer. Death is not the biggest fear we have. Our biggest fear is taking the risk to be alive. The risk to be alive and express what we really are. I think that's very true in COVID times. Don't you think so? In the pandemic, risk to be alive. You know, you have to look at so many things, especially when you're in a healthcare field. You need to be aware of all your surroundings and how you are attired and how close you are with your patients, your team members, etc. So, taking the risk to be alive is very true in these times. Octavio Paz is another Mexican poet. Does this name ring a bell? Anyone? He's very closely related with India. Do you know in what way? Anyone wants to post in the chat box?
Not yet, Shoba.
Okay. No? A few more seconds. Right, Octavio Paz, a Mexican poet who actually studied to be a lawyer, but then he ran away and then he became a poet later on. But he completed his um, education from different universities around the world, and he was a diplomat. So he was Mexican ambassador to India in the latter part of the 80s. So Octavio Paz is very familiar to Indians. What he says about death is a civilization that denies death ends by denying life. So to die peacefully is everyone's right, is what he means probably by that. Khalil Gibran, again from Lebanon, who migrated to US during the Ottoman rule, says that for life and death are one, even as the river and the sea are one. So all of them see life and death as one, all the philosophers and all the poets in the world. Okay, so Rabindranath Tagore has talked about that as well, and that will come to in the latter part of the presentation. Is someone talking? Can we mute, please? Okay, so have you ever thought of your own death? How it should be? We talked about what stirs in your mind, what sort of, but we didn't talk about what sort of death would you prefer. Do you want to be in the hospital, home? What do you want it to be? Family, friends, or only God? Any takers?
Not yet, Shoba. Probably we are waiting.
In Tamil Nadu, people celebrate death. Or
No, that I posted.
Okay, okay, right.
I mean, like this is regarding, quick and hopefully pain-free lose. Uh, of course, we all want to have a peaceful and pain-free death,
Yeah.
no matter where. And I think about when someone close dies. Yes, of course, surrounded by loved ones. So we would like to have a peaceful, quiet, pain-free, without suffering, surrounded by our loved ones and with family, and again with no suffering.
Right, okay. So I think my mother keeps saying, the best way to die is to go to sleep and never wake up. Yeah. So you lie down at night as if you're going to bed, and then next morning you don't wake up. So she says that's the best way to die. Do you all think so too, or do you have a better way? You think?
And Shobha, I mean, a couple of posts with respect to place. Place doesn't matter, but they want it to be very peaceful, without
Yeah.
suffering. That that we will address later, I think. Okay,
Yeah.
let us go to Ramesh now.
Right. Okay. So we generally talked about death and dying and the things about uh, things that can probably influence death or disease condition and things like that. We'll talk in a minute. I think we'll come to the latter part of the presentation and we'll talk about it. So coming back into the clinical narrative that they've had for the past 3 days. Mr. Ramesh, his condition has deteriorated further, and it is clear that the aim is good end of life care. So he cannot be, he's not recuperable in the sense he cannot be retrieved back into uh, his general condition that he was before he got COVID. The medical team decided to call a video conference, including the whole family, and the family expressed a wish to take him home for end of life care. Now, whether this happens during COVID, if the patient has COVID, is a question. Because I don't think that is happening in Kerala at the moment, but there are definitely plans, is what I understand from the government officials. What they say is that probably it will happen in the near future, where patients with COVID can die at home. I don't know whether I don't think it's happening in any other part of India, as far as I know. If anyone knows, you could please put in the chat box. So, how do we ensure good quality end of life care? What do you think? Can you please post in the chat box?
If the person is positive, for 17 days, they are allowed to go home. Could you explain that? What did you mean? Home isolation. Okay, okay.
No, we are specifically talking about end of life care. The patient is deteriorated further. We're not talking about somebody who's been diagnosed with COVID, has become negative in the hospital, and the patient is going to go home. Of course, they have to remain at home for a stipulated time. I think it's 2 weeks, if I'm not mistaken. So you need to look at the protocol and then decide, okay, this patient is going to be homebound for so many days, and then he can resume his duties. But we're specifically talking about somebody who's, uh, diagnosed with COVID and he's going home, which is not happening at the moment. But how can we ensure good quality end of life care? Suppose our hospitals become overflow, with COVID patients, and we don't have place. So people who are dying, we might have to send them home. Any points for discussion? Okay.
Shobha, Lou says that, he meant end of life care. The person is still positive for 30 days
Okay.
in immunocompromised patient. So I think he might be thinking in terms of kind of home isolation for not only for the patient, for the family members as well. Now we are talking with respect to Ramesh, and suppose if Ramesh is going to be, we are not sure whether Ramesh can be taken home or not, because it is not like any other end of life care scenario what we witness in palliative care. This is COVID-19, which is it's got high infection rate, so there are a lot of issues if we have decided to if we decide to take Ramesh back home. So here we are going to focus how we are going to give him good quality of care as he approaches his end of life phase. Irrespective of the fact that whether he is at home or in the hospital. That is what many of you have commented, that the place doesn't matter. You want to be the end of life phase without suffering, should be quiet and peaceful, pain free. That is what we are trying to focus here. I think that's a track you are planning to move on, Shobha.
Right. Okay. So let's move on to the next slide. Okay. So why end? Let's talk in general terms. Why end of life care is important. Okay. This was in 2015, the quality of death ranking end of life care across the world. And you can see that UK is the best place to die. UK is the best place to die, the birthplace of palliative care. And India is 67th position of all the different 200 odd countries, that even more than that. How many countries? I'm not exactly sure. So India's got the 67th position, which is like low ranking, I would say. So we still have miles to go before we sleep. Okay. So what were the indicators of quality of death? Palliative and healthcare environment. Whether these countries had good palliative care, and what is the healthcare environment in such places. UK has got the NHS facility wherein people can just walk in, and the taxpayers pay the bill. They have to just pay minimum amount of money when they get home with discharge medications. So the other indicator was human resources, whether people were trained and available for end-of-life care. What is the affordability of care? What is the quality of care? So even if you're trained and if you're not willing to impart that quality into your care, you have all the knowledge in the world, but you still are not ready to sort of look after the patients, then the quality of care comes down. So that is another indicator. And the community engagement. Is the community ready to help you? Are there volunteers to help you? Of course, it is there in Kerala and different parts of India, but it's not uniform throughout, as it is not, and it is not uniform throughout in UK either. So, uh, so these are the indicators of quality of death. So Jan Sternsward is an oncologist turned palliative care physician. So a very well-known figure in the field of oncology and palliative care. What he said was, we ought to give those who are to leave life the same care and attention that we give to those who enter life, the newborns. Okay, which we rarely do. When somebody's being born, we are quite happy, and when somebody's dying, as people said, we feel sad, and fear, etc., etc. Okay, relevance and challenges of end-of-life care in the context of COVID-19. We've been discussing this in the past few days, I think, because this kind of a scenario is not quite common, and it is very new to because of this pandemic, because we really don't have time to actually communicate with these patients and their relatives as to what to expect and what is going to happen and things like that. I'm sure the communication skills were taken yesterday, and you've gone through thoroughly what you can do in the limited time frame that you have. So definitely that is a constraint. We do not know the patient. We haven't actually had a rapport with the patient and the family. Normally in palliative care field, we know these patients for some time, and we have a good rapport. Most of the time we have a very good rapport with the patient and the family, and there is some amount of trust. Here we don't have time to develop that trust, so it becomes extremely difficult. Okay, so acute illness with fast progression, less time for preparedness, limited information, dilemma and decision making from the healthcare professionals point of view, information overload, and we get things forwarded in this technical era. Uh, Anything and everything is forwarded, and we get loads and loads of information. We really don't know which is right and which is wrong. Isolation from family members, complicated grief for the patient, personal protection equipment hinders effective communication, obviously. And more than that, I would say added on to that is the personal discomfort in actually donning the protective equipment and moving around. It's absolutely baking inside that, and when you're actually working, and then you're just waiting to get rid of it. So sometimes this kind of discomfiture will not allow you to give your 100% towards that patient. So we have to actually train our minds to be adjusted to that kind of a scenario and then provide that care. Inappropriate artificial life support measures adds to suffering. So NIV and those kind of things, is it going to help really? And if the patient is not conscious, and suppose the patient has got hypoxia long before and then is nearing brain death and that sort of a scenario, and then we are trying this patient on NIV, we are not going to do a great favor to him. So we need to be extremely careful and clear and ethically correct in what we do. And how do we do that? It's very difficult because small hospitals and nursing homes in the periphery and rural parts of India do not have an ethics committee. So all you can do is, if you're a young physician or a young nurse and you're a young paramedic or volunteer stuck, then you need to definitely speak to your seniors and who has got good experience, or look at your protocol. If there's nothing else, look at the protocol in your state and then follow the orders. Okay. Avoiding futile or inappropriate management. The ICMR on 12th March 2018 came up with the definition of terms and explanation. Withholding or withdrawing a potentially inappropriate treatment in a patient dying with a terminal illness cannot be construed as an intention to kill. Right. So we are actually taking a decision not to intubate a patient. Okay. That doesn't mean that we are murdering that patient. So the intention is not to kill the patient, but for nature, allowing nature to take its own course. So that needs to be very clear. The term passive euthanasia is an obsolete terminology and should be avoided, as euthanasia cannot be passive. I think on the first day, Jennifer and Moira would have talked about ethical issues and other things, if I'm not mistaken. So there's a lot of dilemma as to whether we should actually intubate or not, and when the patient is old or young, should we intubate the younger patient first and leave the older one for later if we have only one ventilator? There are a lot of ethical issues around that area. So, but we are talking about, here is a patient who has gone past all that, and the family has expressed a wish to go home. Okay, to die. So we're talking about that kind of scenario. So how can we ensure that he dies with dignity, right? So ensure patients' comfort through appropriate symptom control. And if we've been discussing symptom control in the past 3 days, so we have to refocus medical and nursing care, like prevention of bed sores and skin care and catheter care and mouth care, etc., etc. Avoiding unnecessary interventions, reviewing all medicines and symptoms regularly, maintain effective communication. Okay, I'm sure that would have been discussed yesterday. Provide psychosocial support for the family members. So we have to actually discuss what are the goals of care. Is it symptom management, making the patient comfortable and allowing the natural process of death without suffering. Transition from intensive care to palliative care approach, consistent involvement of palliative care team, psychosocial support for family, and of course the end of life care is not complete without bereavement support. We'll discuss that in a minute. So we've discussed about all these things in the past. Psychosocial support, etc., would have been talked about yesterday. So what are the strategies for effective end-of-life care symptom management? So what are the different symptoms that we can have? Breathlessness, agitation, pain, fever, secretions, pressure injury, most of which we have discussed on the second day. Appropriate personal protection equipment should be used while managing the symptoms. It goes without saying. So Does everyone have injection morphine in wherever they are working? Injection morphine and oral morphine, do you think? Most of the facilities will have injection morphine, but what about oral morphine? Do you have oral morphine with you? Just a general sense. The colleagues from Philippines have they joined, and from Nepal, do you have morphine um, in your hospitals?
Yeah, so for many of them have access to both intravenous, I mean parenteral
And
as well
oral
as
morphine. Great.
morphine,
Okay.
I mean oral
That's.
morphine, and
Mm.
they are, I mean, they have quite experience in giving morphine both for pain as well as breathlessness. That is what
Excellent.
I had understood from the
Yeah.
symptom management session. And
Excellent.
many of them are familiar with the subcutaneous administration of drugs as well, but not with subcutaneous administration of fluids.
Okay. So injection morphine 5 milligrams subcutaneous, 2.5 milligrams IV, and injection midazolam 5 milligrams subcutaneous, 2.5 milligrams IV. So it's just tentative. These doses are just tentative. It depends on you and how you see this patient. If this patient is very well built and severe symptom, there's no harm in giving a higher dose. But we normally start with uh, in our practice, we start with 2.5 milligrams to 5 milligrams, both IV or subcutaneous. If you don't get an IV, we would give subcutaneous. Injection midazolam, again, the same range of doses. Give both drugs every 15 to 30 minutes until symptoms improve. Okay. Then starts continuous infusion if indicated of injection morphine 30 milligram and injection midazolam 15 milligram to 60 milligram subcutaneous IV over 24 hours. So we've gone above 30 milligrams too in our practice. I'm sure many of you would have gone through that. I'm not, or at least some of you would have gone through that continuous infusion with morphine when there's continuous pain, especially in a palliative care setup. Injection midazolam 15 to 60 milligrams of subcutaneous IV over 24 hours. Now, there are ethical issues in this kind of a scenario. First of all, COVID-19, it's a vasculitis more than a lung pathology that it causes. So vasculitis in the lungs causes a lung pathology. So basically vasculitis, it causes dyspnea and hypoxia. So in that kind of a scenario, when we are actually causing hypoxia, we're giving these medications. So are we pushing these patients over the brim? So there is an ethical issue here. So we need to be extremely careful. So we'll discuss that probably in the next 2-3 slides later. Okay. So for agitation, we can give injection haloperidol 20 milligrams and injection midazolam 30 milligrams as a continuous infusion, just the same that we discussed in the symptom management. Pain and fever, paracetamol, we know the dose. If the patient is already on opioids, continue according to the response. Pain assessment could be difficult as the response will be either sluggish or absent, and beware of altered renal function in these patients. So the doses need to be adjusted for the renal function. Secretion, suction is avoided because of the COVID scenario and aerosol spread, and position change to facilitate the drainage. Anti-sialogogues or anti-secretory agents may be used if secretions are troublesome. So glycopyrrolate or high-C butyl bromide can be used. Atropine, because it increases the heart rate, probably a very minimal dose, 1 to 2 drops Q4 sublingual can be used. Okay. Too thick secretions will add to symptom burden. Serostomia is uncomfortable for the patient and facilitate fungal colonization, that is dryness of the mouth, can be very disturbing to the patient. So we talked about physical symptoms. Any questions so far, Raji, in the chat box? Any comments or questions do you need to answer?
I mean, not yet. These were comments for your query with respect to availability and their
Okay.
expertise in using morphine
Right.
for symptom management.
Okay.
And, Rumali has commented, yes, we do. We just don't have the syrup or liquid form. I believe that is with respect to morphine. Is it so? Yes, yes. I mean, probably you will be having the tablet form. That's what you were trying to emphasize.
Right. So sometimes what we do is if the patient has got a rice tube, we can even powder the tablet and mix it with water and push it through the rice tube. So that can also be done if there's no IV access or subcutaneous access. So that can also be done. So we've talked about symptoms. And what about pressure injuries? So care of pressure areas, silent pressure points, which is the endotracheal tubes, NG tubes, masks, etc. I'm not talking about endotracheal tubes, particularly in COVID patients, but generally. And pressure reducing mattress can be used. Skin care, avoiding soiling and talcum powders. Here, Raji, do you mean to say that we avoid talcum powders? Is that what you mean?
Yeah, that's what in the
Mm.
common. I mean, uh, in the community. I mean, I want to emphasize the fact that in the community, and when we go for home care, we have seen that many patients are, covered with talcum powders. I should say that because I mean, they might, the family used to get that message from probably from neighbors or from some other people that when you apply talcum powder, that will protect you from other sores and all that tissue irritation. So usually they will apply talcum powder whether they give bath or don't give bath to the patient. So that should be avoided. So in when the patient is bedbound, and with the moisture which is from the probably from urine or fecal matter or from sweat, and when it is mixed with talcum powder, they will just create kind of clumps, and that will get stuck to the body, and that area cannot be cleansed properly, and it is very likely that pressure ulcer might develop on those aspects. So talcum powder should be avoided in all bedbound patients irrespective of the COVID status or not. That is what I wanted to highlight.
Right. Okay. Thank you, Raji. So the next point is gentle massaging of pressure points, and pressure points in the sacral area, the greater trochanter, the heel, the calcaneal area, etc., and the shoulder area. And when you lie on one side, maybe the ear or the cartilage.
And Shobha, one more point down. All these pressure points are highlighted on the toolkit. They can
Okay.
found
Fine. Fine.
the
Okay. Great.
yeah.
Okay. And moisturizers can be used, not liberally though, but generally, isn't it, Raji? Is that what you mean?
Sorry, you want me to comment on that?
Yeah, yeah. Moisturizers, it can be used not liberally, but
Yeah, it's.
can be.
I mean, nothing should be used in liberal. I mean, appropriate, so as to give the skin a supple feeling. That's all.
Okay, fine. So about too rigid turning regimes, when the patient is actually dying, we kind of tend to sort of stop turning the patient every 2 hours. There's no point. So just leave the patient alone, let him be comfortable. We need to check on him if there's any soiling and things like that. That's a different matter altogether. But you can go and turn the patient maybe once in the morning, once in the afternoon, once in the evening, once at night. And I think that will suffice. Not every 2 hours like we would do an ICU patient. Okay. So can Ramesh be taken home? So Ramesh's condition has deteriorated further, and it is clear the aim is good end-of-life care. Medical team decided to call a video conference, including the whole family, and the family expressed a wish to take him home for end-of-life care. How do we ensure good quality end-of-life care is what we've been discussing. So we know about the symptoms and how we can manage the symptoms, but how do we make it happen? What are the logistics is what we need to discuss further. So that's why I said, in your own state, wherever you work or in your country, what are the protocols and what help can you get to make things happen? And if a normal patient, if Ramesh was not COVID positive and he was dying from some other disease, even then, the people who go home to look after him or make home visits they have to follow a lot of protocols. So those kind of things, you need to be ready with that kind of pamphlets and literature and things like that. So what is the government directive about care for COVID-19 positive patients at home? So that we need to look at. So even if allowed, how can care be given at home, and how will the neighbors react? So the care given at home, the family members, they probably have to be PPE clad and then look after this patient at home. And now, if somebody has got COVID, who's cleared of COVID, that person does not have immunity, And you can never say that he's not going to get COVID again. And there have been instances where people are getting a reinfection. So we can't say that, a COVID-19 patient family member should go and look after him. So I don't know how that is going to be possible. And how will their neighbors react? So if somebody's dying at home, even with COVID-19 patients at home, or even with healthcare professionals going back home from the hospital looking after COVID-19 patients, there have been worldwide, there have been, not only in India, but across the world, there have been different a kind of ostracization towards healthcare professionals. So you can imagine somebody who's dying at home and what ostracization the family would face. So, um, how are we going to respond to that scenario? So, we need to actually educate people about caring the patient, disinfection, disposal of waste, following protocols, etc. There will be, lack of professional support. Um, there will be inexperience in using medicines and medical gadgets, inadequate supply of medicines and PPE. There'll be a lot of emotional distress. Am I doing this right? Is this the right way to do things? Guilt, fear of contagion, anxiety, etc. And isolation due to quarantine. And stigma from society. So all these things go through the relatives who are looking after this patient. Um, and it's an extremely difficult scenario to handle. So what are the strategies? And an appropriate training of the family member for using medicine and gadgets, like we said, counseling and regular support by phone calls, regular updating with latest guideline protocols, and liaising with local healthcare authorities, which can be done. Sorry. Effective communication challenges, high emotional distress, barriers to communication, of course, physical as well as lack of knowledge. What do we say and that sort of thing? So barriers to communication, highly emotional kind of a scenario. So what, as healthcare professionals, what we can do is we can explore concerns. We can listen to them actively, the least that we can do. We can share information. Okay, this particular area has these many facilities there. You could contact this person, or this is the government guideline, or this is the government facility available. We could go there for help. Acknowledging reactions. The patient or the relative is feeling distressed. You acknowledge, we understand what they're going through, and express empathy. Now, there are different articles which says expressing empathy is not enough. Yeah, I agree with you. I understand what you're going through, and we do nothing about it. That is not So we need to be compassionate. And what do you mean by compassion? Compassion is just acting on your empathy. So action on empathy is compassion. So we are kind of doing whatever is possible within our capability to look after this patient. So expressing empathy alone probably might not suffice. Um, we need to support the family as well with complicated grief, because they're not even able to hug the person who's dying. Quarantine issues, stigma from the society, regular bereavement support by means of telephonic, WhatsApp, chat, or video call wherever and whenever possible. This can be done. So I was talking about it's of end of life care. So are we justified in giving this kind of continuous infusion for such patients who are suffering from these kind of symptoms? Are we actually killing the patient by giving midazolam 60 milligrams and morphine 30 milligrams? What do you think? Can you all put in the chat box, please? Are we pushing the person to die, pushing the person to death?
Shobha, I have
Yeah.
given a question in the chat that what kind of death do they prefer, first or second? Because I mean, a couple of comments were there in the chat box already. Because I mean, we don't mind where the place is, but generally people want a peaceful, uh, no suffering. I mean, pain-free death. So I mean, this is the first picture depicts a patient on her bed, probably at home. We are not sure, but anyway, we can see a syringe pump that can be at home also, as well, because it's a picture from the west. And in the second, it's obviously from ICU. So complete focus on quality of life, death as well, and not prolonging suffering. Loads comments.
My question was, are we pushing the patient to death when we give 60 milligrams of midazolam and 30 milligrams of morphine?
First, I mean, do the question which you asked and I asked, do they differ? I was just commenting on the photograph. Did you ask something different? I mean, I
Yeah,
didn't get that.
you were, so I asked whether are we pushing the patients to their death when we give 60 milligrams of
Oh, fine.
midazolam and 30 milligrams of morphine? That is the ethical scenario, isn't it?
No, Pallavi doesn't think so.
Okay, great. Okay, right.
Paying leave.
Anyone else? Differing opinion? When I
Yes.
said great, don't think that that's the right answer. So, anyone else?
Yeah, that's what. No, we are not. We just want them to be comfortable. Outcome will not change.
Right. Okay. So our it might or might not. We do not know is the correct answer. But our intention is actually to give the right amount of medication to control this person's distress, which could be agitation because midazolam is there, or which could be breathlessness as morphine is there, or pain, whatever it is. So we are just giving the right amount of dose to control the symptoms. Our intention is not to push the patient over the brim. So as far as our intentions are clear, we are not held guilty. So this is known as the doctrine of double effect. Was this discussed during the thing, ethical discussion in the first lecture? Doctrine of double effect? So there is an ethical theory called doctrine of double effect, and if you don't know, it's nothing major. It's nothing. Um, is You can always read it up. It's so because our intention is to actually take care of the distressing symptom, and our intention is not to kill the patient. We are still entitled to give the right amount of medications in dying patients. So that's not an ethical issue at all. Okay. Right. So any more answers or any points to discuss right now, Raji?
No, so
Okay.
far no, because
Okay.
these were comments, no
Right.
questions.
So when the fine laws are properly managed, the family members and caregivers feel confident. If it is improper, then patients end up in needless suffering. Yeah, a sense of final gift giving, good death is there when it's properly managed. And if it's not, family members live with frustration, worry, and guilt. An opportunity for growth is lost for whole caring team. Whereas a sense of growth in all the members of the caring team will be there at the final hours if it is properly managed. Goes without saying, doesn't it? Recently, we sort of didn't manage a patient very well, a patient who died because he was in a COVID isolation ward. He came with a CA esophagus, and we couldn't get him out on time to do an X-ray because he had breathlessness, and he had a huge pleural effusion, which if we had tapped a little bit earlier, maybe he would have lived for a few more days. So um, we have we have gone through that as well and feel extremely let down that we couldn't act because the machine to be taken to that area and that COVID isolation area and all sorts of logistical problems that we had to face during that scenario. So it happens with even with years of experience and going through your routine palliative care ward rounds and things like that. So each and everything you have to be extremely careful. And when we postpone, okay, now the COVID isolation ward will not take an X-ray now, probably will take the day later, and this is what happened. So that was a scenario where our team didn't feel very good because normally we've always pride ourselves in looking after patients well till the last day, till the last minute, last second, and even after that, we give support to the family. We tend to call them up, or they themselves call us up, and then we have a small chat with them, which is very nice. Okay, now Ramesh has died, and his family have expressed their thanks, and he was not alone and did not suffer for long. And they found the opportunity to speak and see him over the phone so helpful. and you're doing a home visit face to face or by telephone to offer support, and you find the family particularly distressed as they could not carry out the prayers and funeral rites. You know, there's a team in Trivandrum in Kerala. There are a lot of ladies who work there, and they are actually doing the last rites of people dying with COVID, and they've become kith and kin to these people. And it's a big salute to these ladies who are working in that kind of an area. Okay, they say our neighbors don't even greet us anymore, and we've lost the heart uh, of our family, you know, and how will we ever be at peace? How will you respond? What are you going to say? Do you have any answers?
Please post your comments. And the family says that, you know, they have lost the heart of their family. What kind of reaction is this? And how should we address that?
Everybody's tired. Are you all awake? I hope you're all awake.
We have 10 more minutes to go.
Yeah. Right. So you're at loss of words sometimes, isn't it? You don't know what to say, and how can we make a sense of all this? So what probably you need to think is, if you yourself put yourself in their shoes and say that they really might be scared, but that doesn't give them the license to be rude to you. I agree with that. They haven't been rude, but you're a little worried about their reaction and that sort of thing. So you're legitimate. So what you do is you legitimize their feelings, and they say yes, this can happen, and you're sure to sort of feel bad about your neighbor's reactions. But I guess that will pass soon when this clears up. That sort of thing. How it depends on what kind of a rapport you have with these patients as well. So grief is a total human experience. It's not just one facet of your life. So it is emotional, it is cognitive, it is social, it is spiritual and physical. You have physical pain, you have emotional pain, spiritual pain, social, and why did this have to happen to this person in my family? That sort of thing. So grief is total in nature, as is palliative care. So bereavement in the pandemic, more complicated due to the changes in the traditional societal mourning process. Funerals, burials, and gatherings governed by strict guidelines, which are changing now. So the take-home message is focusing comfort of the patient, appropriate treatment, stopping futile interventions, effective communication, support of the family during end-of-life and bereavement phases. And as I was talking, Rabindranath Tagore, accepting death as it comes. Death is not extinguishing the light, it is putting out the lamp because the dawn has come. What beauty to those words. No wonder he got the Nobel Prize. So another American writer, Gail Forman, is that what death would feel like? The nicest, warmest, heaviest, never-ending nap. If that's what it's like, I wouldn't mind. So the list of resources. So what, in summary, what we were talking about is death and dying is a very heavy topic for us to handle, and when people are dying in front of you, it is our duty to look after them and not to run away from it, thinking that we've done everything. As doctors, we need to preserve life, but we're not entitled to look after people who are dying. We are definitely entitled to look after people who are dying, not only the people who are dying, but also the family members. And that's why bereavement should be there in place, and so that we can support the family. So these are the other resource and training, and these are the contributors. Now I want to show you something else. We'll stop share for a second and show you something else.
So
I put
Shobha,
my, yeah,
they have, I mean, sorry, they
yeah,
have commented, with respect to the case scenario
yeah,
after the Ramesh death,
yeah.
like the slide showing trauma, grief, and loss. They have commented that the reaction could be part of the grief, and it has to be acknowledged and validated. Their validated, and their concerns and feelings should be acknowledged and appropriately validated. That were those were the comments in the chat box.
Okay, great. Anything else?
Any other point which you should, you would like to discuss? This question
Yeah,
is to participants.
yeah. So I was thinking that there's a very good book by Sadhguru, which, if I hope all of you can see, which says "Death: An Inside Story," which is an excellent book, which I've started reading. So he's talking about, these are things which might equip people, normal human beings like us, to know a little bit more about what actually transgresses when you leave your life. So he's saying, or the people who have, I've just started reading the book. I don't know much about it, but what the essence that I got was, there is a physical, psychosocial, psychological, and metaphysical aspect towards dying. So the physical aspect, that the scientific world has come in terms of the physical aspect. That is, when you're born till your death, it's a physical form that you treat and then you look after. So the modern scientific world, where we practice our medicine, does that. But before that, where will you? And after that, where are we going? Nobody knows. The better physical aspect, even the psychological aspect, the emotion and things like that are taken care of. So it would be an interesting read if some people can, look at it, and it might give you an enriching experience about life and death. And once you uh, amass this kind of knowledge, maybe it will make you equipped to deal with death and to answer the relatives questions and things like that, which would be a good tool to have. But what was said and done, even if you have dealt with immense number of deaths in your career, you still squirm in your chair when you're talking about end of life care to the patients and their relatives. All you can say is that he needs to be looked after, and he needs to, be treated in a very gentle, dignified way. Any further questions, please? So there's a question from Tricia, which says, Raji, there's a question from Tricia which says, any.
Does your government have a protocol allowing COVID confirmed patients who are dying to die at home? I mean, that's what. India, not yet. I mean, I am sitting in Kerala and Shobha too. We don't have a policy with respect to people dying with COVID being cared at home. And India government also has not sanctioned, that kind of care yet. But it is said that in the West, I mean, high income countries, it is practiced. It is not in practice in low middle income countries like India. That is what I know. Shobha, do you have any comments on that?
That's what I kind of inquired with the government doctors here today, just to find out if because every day new things come up. So I have not been talking to them for some time. So I kind of rang them up today and asked them, um, has it changed? So is there any protocol which says it's going to happen, is what I hear.
Yeah, if the
COVID,
mortality rate, if it is going to hike, and if most of the hospital beds, particularly ICU beds, are filled up, then that is only option. But that is not the scenario which is being there currently. I mean, currently in Kerala as well as in India,
right.
we are not exhausted with our hospital beds. Rajam madam is, I think she also has logged in. Would you like to have any comments, madam? So Rajam, Dr. Rajam Iyer, among the
Right.
participants, would you like to have any comment?
Yeah, so Rumali Corbera has commented that offer bereavement support, valid that what they are feeling is a normal response, and also extended spiritual care to the family irrespective of their faith. Yes, that's kind of validation too. Definitely, yes, absolutely. Acknowledge the situation, spirituality brings comfort too, which is Lourdes Sores, if I'm pronouncing it right. Uh,
So I would like to ask a question to the participants. How many of you are, how many of you have the experience in managing symptoms? I mean, not end of life care, managing symptoms of patients at home. See, all of us being doctors or nurses or even the paramedics have the experience of treating the patient or managing the symptoms at hospital setting. But how many of you have that experience or exposure in a home care setting? On the chat box, please. Okay, one person does. Oh, very good, very good, very good. Okay. So, what are the usual symptoms you encounter in home care setting? I mean, like the common symptoms which you had to palliate or manage. Because tomorrow we are going to have a session on addressing the distress. So all these unrelieved symptoms can escalate anxiety and cause, distress among the patients and the family members. So that is the reason why I asked. I mean, it need not be palliative care, but like diarrhea, pain, any symptoms which bother, any symptom which bothers a patient. I mean, it can be mentioned. Need not be like symptoms pertaining to palliative care patients. Okay, diarrhea, pain, fever, persistent cough, shortness of breath. Oh, fine. Good. So do you use, I mean, ascites, pain? So, okay. So Shobha has put a question. Pallavi, do you look after HIV patients? No. Pallavi's answer comes as no. Okay. So you give morphine in home care setting as well? So you carry morphine with you? Or how do you give morphine at home? Do you carry that, or you would request a patient to come to your clinic or organization to collect it? General complaints, upper respiratory symptoms. Fine. So Rodora, if we have supply from government, we carry it. Otherwise, they buy. Oh, fine. That is good. Okay. Issue
Right.
prescription. They can buy from the nearest drugstore as long as they carry the special prescription. You
So
mean
is
special prescription for morphine?
so is Arabella, Tricia, Rodora all from Philippines?
Yes.
Okay, great. Okay. So I think in summary, like when you're talking about end of life care, whether the patient has COVID or not, the symptoms that these patients can have is breathlessness, agitation, pain, and we know how to deal with these symptoms. Anxiety, phobia, yes. So midazolam, morphine, haloperidol, these are the things that we are focusing on as per the medical intervention is concerned. So we need to have these medications in your kit all the time as an emergency thing if people are you're going home to look after them and people have end of life care issues. So it goes without saying that these are really really helpful, and of course the anti-secretory drugs like Buscopan, which we call in our country hydroxyl butyl bromide. Hydroxyl hydrobromide is there, but hydroxyl butyl bromide is very effective, and glycopyrrolate. So remember these essential drugs, and of course the other things goes with that, the compassion, the logistics, etc. Need to be in place. So thank you very much. If there are no questions, thank you for your kind attention. Right?
Thank you, Shobha.
Yeah.
Thank you.
Okay.
Thank you all. Thank you, Arun. And uh, you have to post your feedback, whether that's a separate link